Good morning to all. My presentation is titled Keratic Precipitates, an Overlooked Sign of Microsporial Stromal Keratitis. So to introduce my topic, microsporidia are unicellular eukaryotic organisms which have been reclassified as fungi. In the eye, they may cause keratoconjunctivitis, stromal keratitis, or endophthalmitis. Stromal keratitis is generally described as multifocal, coarse, anterior to deep stromal infiltrates. Due to lack of distinctive clinical features, it is commonly misdiagnosed as viral or fungal keratitis. In addition, it does not grow in commonly used microbiological media, and it requires a high degree of suspicion to be recognized, to be diagnosed in corneal smears. So in a retrospective study by Sambaparin et al., they found that most of the cases referred to their institutes had no clinical diagnosis and were being treated empirically, while a large proportion of the cases were being treated as HSV stromal keratitis or fungal keratitis. So in order to look for distinctive clinical features, we conducted a retrospective observational study between 2016 to 2022 at LV Prasad Eye Institute, Bhubaneswar. The inclusion criteria was histopathological or microbiological diagnosis of microsporidial stromal keratitis, and the exclusion criteria was a coexistent infection. So a total of 18 cases were found in which careful review of slit lamp photos revealed keratic precipitates distributed beyond the area of stromal keratitis. So this is just an overview of the cases that we found. 2 of the cases had a history of trauma, one with a pebble stone and one with caterpillar hair. The duration of symptoms ranged from 12 days to 5 months. 4 of the cases had a history of previous treatment. 3 were being treated empirically and 1 was being treated as viral dendritic keratitis. In our institute, the diagnosis of microsporidia was made with with scraping of corneal ulcer in 2 cases, and by histopathology in the remaining 3 cases. Most cases, therapeutic PK was done, and most cases were unsuccessful due to various causes, whereas 1 had a clear graft and 1 was managed medically. So these are some of the slit lamp photos showing the distribution of keratic precipitates beyond the area of the lesion. So just to provide a summary of 1 case, this was a case which was initially suspected as viral dendritic keratitis and was receiving treatment for the same. After a duration of 1 month, a central stromal infiltrate was found with stromal edema and pigmented keratic precipitates away from the lesion. So based on this clinical feature, we suspected microsporidial keratitis, and a corneal biopsy was done in which microsporidial spores were found. Due to worsening of the condition, therapeutic PK was done, followed by cataract surgery, followed by final visual acuity of 20 by 160. And in histopathology, microsporidial stromal keratitis was found. So just to reiterate, microsporidial stromal keratitis is generally described as either anterior to deep stromal infiltrate with surrounding stromal edema and exoedetes, or focal or full thickness monofocal infiltrate with overlying epithelial defects. Keratic precipitates are clusters of various inflammatory cells which are deposited onto the corneal endothelium from the aqueous humor. Keratic precipitates can be described on the basis of morphology, either with a slit lamp or in vivo confocal microscopy, based on their size, color, and distribution. So features of keratic precipitates that suggest an infective cause are the presence of pigmentation if they extend beyond the midline, if they are clustered centrally or paracentrally with sparing of the inferior cornea, and in vivo confocal microscopy if they have a dendritiform or infiltrative morphology. So in our cases, we found that most of the cases were small, pigmented, and were distributed beyond the area of stromal keratitis, beyond the midline. So this contrasts with the typical feature of herpetic disciform stromal keratitis, where keratic precipitates are situated within the and presence of this distinctive feature tailor management accordingly. Thank you.
Nice presentation, Dr. Ipsita. Would you give importance to the presence of keratic precipitates in such cases in the absence of a microbiological histopathological diagnosis? Will just the presence of KPs with the clinical picture help you aid in making a diagnosis of microsporidia without microbiology?
If the case is not improving with the present therapy that we're giving, then we can give treatment for microsporidial stromal keratitis. in the absence of histopathological microbiological diagnosis.
And my question was, do you notice, you have just described 5 cases, did you notice them at the time of presentation, or do these come later in the course of the disease? Because many times these are very protracted also. At what point in the treatment course did you notice these KPs? Did you
At
notice
the
them at the time
time,
of the first presentation?
they were generally being treated as other cases. Like at the time of their presentation to our institute, we generally notice keratic precipitates away from the lesion. So usually these cases are indolent. They usually present to our institutes at a later stages only. And at that position, we can see the distribution of keratic precipitate beyond and have a sort of suspicion and tailor management accordingly.
So you noticed them at the time of first presentation. Is my question.
So, what is the message you trying to convey to the general ophthalmologist?
Excuse me?
Do you trying to give any message to that general ophthalmologist?
Yes, if there is a case which looks like viral or fungal, and we are giving treatment for the same, however, it is not improving, and we notice that there are keratic precipitates distributed away, we can have a clinical suspicion that it may be microsporidial stromal keratitis and conduct investigations accordingly, maybe do a corneal biopsy, and then give management.
If you have the facility, would it be prudent to also take a PCR in such cases to rule out HSV, VZV, or other viruses
Yes, we
which
can.
cause keratouveitis? So, agreed, microsporidia is there, but you'll also know whether there's a co-infection.
Yes.
Was it done in your cases?
In some cases, we also did, but based on these 5 cases, we found that based on histopathology as microbiology, it was microsporidial.
Okay, thank you.
Yeah, nice presentation, Dr. Ipsa. Did you check corneal sensation in all the cases?
Corneal sensation we checked. In some cases, it was, mostly it was not present.
Because the most common differential of this entity, I think
HSV.
it's herpes. So it's one of the very clinical, important clinical parameter that you need to do in all the patients. Right, thank you.